All right, I think I'm recording. Welcome to video assignment number 6, part 1. I'm Kyle Ortega. This is gonna be a little different than the previous assignments. I'm pretty much just gonna go through like a patient scenario kind of thing. I don't really have a PowerPoint besides my pictures of patients in our team. So I'm gonna go through skit that you laid out for us, and then we'll talk about my role in successful weaning and removal of that positive pressure assisted breathing from our patient here that I'll introduce shortly. Then we're going to discuss, some tests that we'll do to measure her readiness to wean, um, how we're going to keep her from failing, extubation, and then things that we're looking at that would cause us to discontinue and resume that mechanical ventilation. Then also kind of going to give you like a hands-on scenario patient assessment of me actually going into a room, talking to her and the family, as you see in the picture, family's present. So just kind of go through my patient assessment, talk to the family, let them know what's going on, and give the doctor my findings and see if we can hopefully pull this tube out today. So that's what's going to happen first. So I'll start from the top. My name's Kyle Ortega. I'm an RRT in MICU. I just returned from 3-week vacation today, and I'm here with emphysema, or excuse me, I don't, my patient, Miss Tuesday, who is on the vent. You see in the picture, she has emphysema, and she's been diagnosed with COPD for almost 10 years. So Dr. Slime, who you see at the picture at the bottom, she wants to be very cautious about weaning and liberation of mechanical ventilation with Miss Tuesday, because as we seen in the past, it has been different. It's been very difficult. Her, excuse me, it's been very difficult keeping her breathing spontaneously after previous extended stays on the vent. So we want to be very, very precautious and make sure she meets criteria for everything. Down in the pink will be Nurse Joy. That's my cartoon version, kind of look like me, so let's go ahead with it. All right, so first, my role in successful weaning and removal of that positive pressure assisted breathing. So we just want to make sure she meets the criteria to wean, right? Starting with that sedation vacation. We want to see some reversal of the underlying cause of the respiratory failure. We'll start with that PF ratio. We want greater than equal to 150 to 200. And then also we want PEEP below or less than or equal to 5 to 8. And then FiO2, want that less than or equal to 40 to 50%. Heart rate greater than 50, but less than 130. We don't want any fever. pH, we want it greater than 7.25. Hemoglobin, we want that greater than 7. We want there to be a cough, gag reflex, hemodynamically, hemodynamically stable. And then ability to initiate a spontaneous inspiratory, want to be able to breathe spontaneously, right? Um, so that'll be my role in successful weaning. Some things we're going to do to test her measure for her readiness to wean are going to include we're going to look at minute ventilation, one at less than 10 liters a minute, looking at that respiratory rate, less than 30 to 35 beats per minute. Tidal volume, we want that at least greater than 5 milliliters per kilogram, ideal body weight. And then vital capacity, we want 10 milliliters kilograms per ideal body rate, or 1 liter basically, or greater than that. Looking at the NIP, MIP, negative, we want negative 20 or greater, or so when I say greater, we want the more negative, the better. So negative 80 is great, negative 10, no go. RSBI, Tobin index, want that less than 100. SpO2, want that greater than 92%. Oh, the FiO2. So if it's less than or equal to 40%, we want the PEEP less than or equal to 8. And if the FiO2 is less than or equal to 50%, we want that PEEP less than or equal to 5 centimeters of water pressure. And then we don't want any signs or symptoms. We want those to be absent so that we can successfully wean. So to keep her from failing extubation, like I said, we're going to look at her readiness to wean. We're going to start that SBT, which we'll get to in other videos. Just kind of want to lay the groundwork here and paint the picture. Event support, we want to optimize it to help her, especially with we want to decrease that work of breathing, manage her secretions, and then just closely monitor everything, vital signs, making sure everything's kosher. And then so if everything goes successful and we do extubate, we want some provide that post extubation support, whether it's supplemental oxygen, whether she needs some pain management, just if she's in pain, and just making sure she's able to breathe on her own. And afterwards, making sure everything looks good, stay in the room a little bit, monitor. Most importantly, though, is I want to collaborate with everybody. As I'm about to do, I'm going to go in the room, give my patient assessment. I'm going to let the doctor know, Nurse Joy know what's going on, what my findings were, what I recommend, and go from there. But it's not always sunny, and we might have to discontinue and resume mechanic ventilations. So things we're looking at for that would be, so like if we're doing pulmonary, so looking at testing her readiness to wean, doing pulmonary mechanics, all that good stuff. We might have to discontinue if her rate is greater than 35 for 5 minutes or more. Systolic blood pressure increases, decreases more than 20 torr. Diastolic increases, decreases more than 10 torr. Looking at that heart rate again, if it increases or decreases greater than 20 beats per minute from baseline. SpO2, if it decreases below 90%, or with our patient being COPD, 4% from baseline. If that pH goes below 7.30. And then again, just looking at our patient, and if they're, if you see increased agitation, increased anxiety, that's probably not a good time to wean right now. And then BRC hospital, we'll try again tomorrow. Also, when should pulmonary mechanics not even be performed? So if there's cardiopulmonary instability, so that heart rate's increase, you got tachycardia, hypotension with the blood pressure, SpO2's decrease. If PEEP is greater than 8, she could end up with a lot of atelectasis. If the mechanical rate's over 16, that's what the vent doing. That's pretty high, so we don't want that. It's not good to test for pulmonary mechanics. It's not good for weaning. Again, that spontaneous uh, rate over 30, 35, especially if we have pressure support set and she's still breathing, is her rate is still very high. That's not good. So then some regular ones like FiO2, if it's over 60%, that's a top tier of oxygen that we more than we like. If that PaO2 is less than 50, pH less than 7.30. And then this doesn't pertain to our patient, but if she had increased chest tube drainage, flail chest, also if there was no spontaneous respirations after having been on CPAP for that 30 seconds to minute mark, discontinue. We wouldn't even attempt. And then, if pressure support is greater than 10, we don't want to wean yet. And then if she's over sedated, it's hard. A lot of paralytics, a lot of sedation. It's not best to do any pulmonary mechanics. So it's pretty much an overview of everything we're going to do. I'm going to allude more to all this in coming vehicle videos. So next, we'll kind of get into, oops. So just returned from vacation. So I haven't seen this patient. I got a report last night. They said everything was looking good, that we were expecting to wean this patient, maybe possible extubate today. I got a call from the nurse. As soon as I got my phone that doctor, went ahead and started that SAT, a spontaneous awakening trial, to get ready for the SBT from the doctor. So I can't wait to get my hands dirty and get in here, do my patient assessment and see what we got. So before I even enter the room on my computer, I'm going to check the patient's chart. Excuse me. I want to look at the history, diagnosis, um, ABGs, chest x-rays, what medications they're on, doctor's notes about everything, look at their labs, blood count, all that good stuff, just so I get a better idea of what to expect. And then comes the fun part. So I'm gonna foam in, put my gloves on, or foam in, not hi, I'm Kyle, respiratory. I'm just here to do a patient assessment. Put my gloves on and then introduce myself to the family and patient. So I'm Kyle, respiratory. I'm here to do a patient assessment. Doctors, I got a call. Doctors want to maybe possibly start SBT today. Maybe some good news. We might be able to extubate. So I'm just, I'll talk to the family, let them know what I'm doing. I'm going to be doing my patient assessment. I'll chart some things, talk to the team, let them know what I gathered in the room, and we'll go from there and just keeping that family in the loop. So hopefully we can possibly get this tube out of her. So my patient assessment, I'm gonna go in. First things first is respiratory. All we care about is that oxygenation, right? So checking her SpO2, looking at the vent. If I need to see if I need to adjust that FiO2 or PEEP settings. Sorry. Respiratory wise, look at the vent settings. When I listen to breath sounds, look at the chest movement, look at her color. Is there a cough? Is there any sputum? Correct amount, characteristics, and look at her tolerance. See if there's any work of breathing. Is she in any pain? Is she using her accessory muscles? So just going down in my head, what we've been taught about patient assessment and seeing if there's any signs of distress. Cardiovascular, I'm going to look at her vital signs, pulse, blood pressure, look up and look at the EKG or ECG monitor. Is she hemodynamically stable? Make sure there's no hypotension, tachycardia, arrhythmus going on. Check her fluid status. Is she in overload? Is she dehydrated? Neuromuscular. You're gonna look at that level of consciousness, right? Level of consciousness, pupil reflex, see her response to stimulus. Is there any change in mental status? Um, then metabolic, skin integrity. So I want to check those serum electrolytes. Like I said, looking at her charts, want to see what those look like. Skin integrity. Is there any broken skin? Skin look broke down anywhere? Pressure sores, things of that nature. And then most importantly, want to collaborate with the team. We're beginning that SAT. Next, we're going to start that SBT, weaning and possibly extubating. Keep the family in the loop and hopefully things go good. So this will wrap up video number 1. Thank you for listening.